Across the United States, African American women continue to face health disparities. These gaps in health outcomes persist despite advances in modern medicine. These gaps are not random, as they are deeply tied to systemic bias, discrimination, and inequities in healthcare delivery. Many healthcare professionals lack the tools to identify implicit bias, to fully interpret patient concerns, or to apply interventions based on evidence rather than assumption. This training is designed to change that. By analyzing patient scenarios, hearing from experts, and engaging in timed assessments, you will strengthen your ability to recognize inequities, respond appropriately, and deliver equitable care. Your goal in this program is mastery. That means demonstrating at least 85% accuracy in identifying disparities, interpreting patient declarations, and selecting correct interventions. Competency in these areas is not optional. It is a professional responsibility echoed by the mantra of, first, do no harm. Let's begin. To understand inequity, we must define it. As noted by Dr. Williams, health disparities are differences in health outcomes closely linked with social, economic, and environmental disadvantage. My research, including the Everyday Discrimination Scale, shows how daily experiences of discrimination accumulate, shaping stress responses, cardiovascular health, even pregnancy outcomes. These are not isolated events, they are structural.
Martin Luther King suggested that discrimination was a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them. Now, Martin Luther King was not a scientist. This is a hypothesis, though, that could be tested. And I and others have developed measures of discrimination that we could assess. And this is the first paper published. We're reporting the findings of the Everyday Discrimination Scale and documenting what's the impact of the subjective experience of discrimination as one type of stressful experience that had been neglected historically. What is striking about the Everyday Discrimination Scale, it doesn't capture all aspects of discrimination. That is only one of 3 of the measures that I developed, but it's the one that has been the single most predictive. Just little indignities. Being treated with less courtesy and respect than others, receiving poorer service than others in restaurants or stores, people acting as if they think you are not smart or if they're afraid of you or they think you are dishonest. Just a bunch of little indignities. The findings for everyday discrimination are stunning. I am surprised by the strength of the findings. One of my doctoral students just did a meta-analysis. There are over 450 published peer-reviewed papers globally using the Everyday Discrimination Scale. And the next slide is just going to summarize some of the aspects of health that it predicts. People who score high on everyday discrimination, studies show, adjusting for other confounders and other risk factors, more likely to develop metabolic syndrome and cardiovascular disease, an independent predictor of incident breast cancer and type 2 diabetes, engagement in risk behaviors that lead to poor health, multiple indicators of subclinical heart disease like heart rate variation, AFib, intima media thickness are all predictive. Higher levels of hypertension, poorer sleep quality and quantity, higher levels of inflammation and stress hormones like cortisol, shorter telomere length, higher levels of obesity, less engagement with the healthcare sector, and higher levels of mental disorders and psychological distress. Just some of the health outcomes that a high level of discrimination predicts. Today, we have studies from the United States, the United Kingdom, Australia, New Zealand, and South Africa that find statistically, when you look at racial differences in health and you adjust for income and education, there still is a residual effect of race. That effect is further reduced when you add a measure of discrimination to the model. So we now know empirically that discrimination, the subjective experience of discrimination, is a contributor to the racial disparities in health.
Further proving the validity of Dr. Williams' research, here we see maternal mortality rates from 2022 and 2023. The data shows that African American women are 3 to 4 times more likely to die from pregnancy-related causes than white women and other ethnic groups overall. Dr. Williams reminds us that what happens inside exam rooms is only part of the picture. Bias, both conscious and unconscious, is a driver of the disparities we see across health outcomes. Knowledge check. At the end of every section is a knowledge check question. Answer questions to the knowledge checks based on information previously viewed. You can either pause the video to write down your answers or enter them on a digital document or notepad. At the end of training, there will be a comprehensive knowledge check with questions focused on the entire video. Be sure to select the best answers. Knowledge check number 1. What is the purpose of the Everyday Discrimination Scale? A. To measure subjective experiences of unfair treatment in daily life. B. To measure complaints of unfair treatment by Black people only. C. To uncover where racism is more prevalent in the United States. D. All of the above. The answer? A. To measure subjective experiences of unfair treatment in daily life. If bias can harm, communication can heal. Dr. Lisa Cooper informs us that trust is the foundation of healthcare. When patients feel heard, when providers actively listen, and when cultural context is respected, outcomes improve. Her research highlights that racial and language concordance, where patients and providers share a cultural or linguistic background, can reduce miscommunication, improve adherence to treatment, and ultimately save lives. In other words, representation and understanding in healthcare aren't optional, they're life-saving. Studies show that when patients and providers share racial or cultural backgrounds, visits last longer, satisfaction rises, and decision-making is more collaborative. Expanding diversity in the healthcare workforce and providing cultural competency training aren't just strategies, they're essential steps toward more equitable, trustworthy, and effective care.
I also, because of my strong focus on relationships in my upbringing and my keen sort of interest in building stronger relationships with patients, really wanted to focus on the role of relationships, social relationships, between doctors and patients, between other health professionals and patients, between physicians and their community members. So I was really interested in understanding how social interactions and relationships shape health disparities. So that really sort of shaped the trajectory of my work. So, I started out studying patient attitudes and beliefs, but then quickly realizing that patients really talked a lot about how important it was for them to trust their physicians and to have someone who actually understood them and treated them as a person. And so I really quickly transitioned into studying doctor-patient relationships. And one of the things we found in our early work, we used surveys as well as studies where we audio recorded visits with doctors and patients. And we found that compared to whites, African Americans and Hispanics experienced not only lower levels of trust in their physicians, but also less participatory visits. That means that they were less involved in making decisions about their treatment, that doctors tended to dominate the conversation, to just talk more. They were verbally dominant, talking about 75% more than Black patients, and then about 50% more than white patients. So doctors talk too much overall relative to patients, but they definitely dominate the conversation more when talking to patients of color. That the visits sounded less friendly to people who were independent coders of those audio recordings, and that there was less rapport building conversation, less conversation about things like home and work and children and other issues that might be bothering people, and really a more strict focus on the medical issue. We also became interested, me in particular, because I felt that, one thing that might help to address this is if there was a better connection between the doctor and the patient. So I wanted to know whether race mattered, of the race of the physician. And so we studied race concordance. And we actually found that when doctors and patients share racial background, that the visits were a little bit longer, about 2.5 minutes, that there was more participation in the visit by minority patients, that both the doctor and the patient sounded happier, and the patient rated the visit as being more satisfactory. So, what did that tell us? I mean, it wasn't really surprising, but I think what was concerning is that, health professionals should be able to treat all patients with the best quality of communication, and that we shouldn't really be communicating differently with patients based on whether we share social background with them, even though that's understandable. So, and I also knew though that most physicians weren't doing this intentionally, because we had asked physicians about their attitudes, at least their explicit attitudes towards patients of different racial and ethnic backgrounds and income backgrounds. And doctors said, at least as far as they knew, on a conscious level, they didn't feel differently about any of these patients. So we really wanted to study implicit attitudes, because we felt that maybe there was something going on that doctors didn't really realize they were doing. And so, I had been working with behavioral scientists and physicians and, other public health professionals and statisticians and so on and so forth. But at this point in time,
Dr. Cooper's findings emphasize that the quality of interactions, which are listening, respect, and partnership, can reduce disparities as effectively as some medical interventions themselves. Knowledge check number 2. Effective communication between patients and providers helps reduce racial disparities. A, true. B, false. The answer, A, true. Maternal health is one of the most alarming areas of disparity. Dr. Amuta Anukaga reports that reproductive justice frames maternal health as a human rights issue. Black women consistently report having their pain dismissed or their symptoms minimized. This occurs 20% more often than white women during prenatal care. These inequities are systemic, not individual. To address them, we must integrate patient voices into every level of maternal health care policy and practice.
I'm going to chat with you today about maternal mortality and the impact of this on women's reproductive health. So, just to provide an overview of maternal health disparities, the data is not looking good. It's actually getting worse. I just saw an article that was published this morning in USA Today that talks about 83% of maternal deaths are preventable, over 80%. And so we see that the data is moving in the wrong direction. According to the data that we have available from CDC, 60 to 80%, as we saw today, of maternal deaths are preventable. And the maternal mortality rate collectively was 17.4, which we know is much higher now. This was in 2018. So the rates have actually gotten worse over the past 3 decades. So we know that there are multiple factors, multiple reasons, really complex and interwoven, that contribute to these disparities, such as variations in the quality of healthcare, the timely receipt of prenatal care, the access to prenatal care and health insurance, underlying chronic conditions, the impact of structural racism, and how implicit bias shows up in the clinical encounter with the patient. So this data was released in February of this year from CDC. We know that 861 women were identified as having died of maternal causes, which was up from the data in 2019 of 754. So we saw a sharp increase in 107 women over a year, which accounts for a maternal mortality rate in 2020 of 23.8 deaths, which is up from 2019, and it's also up from the data I showed you before. The rates are even more drastic when you look at them by race ethnicity. Black non-Hispanic women were 55.3 deaths per 100,000 live births, which is almost 3 times higher than their white counterparts. And this is for the data that we have available now. And I would like to say that I'm sure that if we were to look at 2021 or even anything preliminarily for 2022, the rates would be higher. They're not going to be any lower than what we're seeing here. So quality of hospital care and workforce diversity. I represent 3% of medical school faculty that are Black. And we know that this lack of diversity within the healthcare workforce has direct implications for patient outcomes, for the quality of care. We saw research that looked at patient and provider racial concordance and the impact of that on Black newborns, Black infants. And Black newborns are more than twice as likely to die during their first year as white newborns. I did my dissertation on infant mortality over 10 years ago, and the data was stark then, it's still the same now. And when we saw that Black infants were cared for by Black physicians, the mortality rate was cut in half. So we know that this physician patient concordance has direct implications for one, lowering mortality risk in infants, but also this plays out in the maternal health space as well. And so just highlighting the impact of creating and sustaining a more equitable and inclusive workforce and the impact that that could have in trying to reduce some of these disparities that we're seeing in Black and Brown women in the birthing process as seen in maternal health and maternal mortality. So what is the reality of racism across the lifespan? How does racism play out in health, and how do these maternal health disparities really show up in Black and Brown birthing people? Well, we know that Black women are twice or almost 3 times more likely to experience maternal death or experience severe maternal morbidity, which according to the American Journal of Managed Care, for every maternal death, there are about 70 near misses, which is just as egregious. But for Black women who really sit at the intersection of race and gender, this creates a series of chronic stress conditions. We see higher allostatic load, a higher impact of physiologic stress on the body, which cumulatively over time creates conditions that deteriorate or weather the physiologic and reproductive health system of Black and Brown women. Now, this type of stress cannot be avoided by higher education, higher socioeconomic status, and the intersection of race and gender is really pronounced and creates an opportunity for one, racism to show up in the delivery of healthcare, and two, the physiologic impact of racism on the Black body. So, understanding some of the issues that we're seeing in racial disparities and just really driving home the point about the impact of racism and how access to quality care makes a difference in the delivery of healthcare and, frankly, for our maternal mortality rates as a country. So, we know that when we talk about the impact of racism in today's healthcare delivery system, the history of obstetrics and gynecology is steeped in racism. Someone that was considered to be the father of modern gynecology, Dr. J. Mariam Sims, who performed unethical, unconsented, really painful procedures on the bodies of Black enslaved women, the ones that we know are Betsy, Lucy, and Anarcha. And that's how we got to really have the techniques and procedures that we experience today. When a cervical or exam is conducted, a pap smear, a speculum, how do we repair a fistula in a birthing person? These techniques were perfected, frankly, on the bodies of Black enslaved women. So this historical context has modern day challenges. We know that Black and Brown women are seen as having higher pain thresholds, are more likely to have their pain or their symptoms dismissed. We saw this in the case of our global superstar athlete, Serena Williams, who almost died postpartum from complications with a blood clot that was forming in her lung. And when she told her provider, her nurse, I believe, that she was having these complications, the nurse told her that she was tired and confused and that she should lay down. What's most interesting about her situation is that she was being treated for this prior to pregnancy. It was documented in her medical records that she had a history of blood clots. And if she had not really persisted and fought, she would have died from the blood clot that was forming in her lung. So we know that systematic segregation and racism shows up based on race and ethnicity. We know that hospitals and clinics that were once designated for Black and other minorities continue to experience significant financial restraints, are often under-resourced, improperly staffed, and more likely to close their obstetric units. A colleague and I, Dr. Alicia McGregor, did some research looking at distance to care and what that means for high-risk pregnancies and complications. And we saw that this is literally a life or death matter, right? These issues result in inequities in access to and the quality and timely receipt of healthcare, which are major contributors to these racial and ethnic health disparities. And while segregation and discrimination are no longer legal, we know that patients, people that attend these clinics, are continued to be discriminated against based on their insurance status. I talk to Black and Brown birthing people all the time about the type of insurance that they have. We know the majority of births in this country are to people on Medicaid and how they have to wait longer to be seen. They're less likely to be referred to a specialist or to get the types of high-risk care they need from MFM or other professional. And these things disproportionately impact non-white populations.
Empirical research indicates that implicit bias can lead healthcare providers to spend less time with Black patients, resulting in diminished quality of care. Such bias often manifests in the underestimation of Black patients' pain and the minimization or dismissal of their reported symptoms. A consistent pattern emerges in which Black women encounter delayed responses and skepticism from clinicians when voicing health concerns, revealing a delicate and often dangerous intersection between clinical intuition and unconscious bias. Reproductive justice is not simply about access to healthcare. It's about dignity, respect, and the right to safe, bias-free care at every stage of pregnancy and childbirth. Knowledge check number 3. A Black woman reports severe prenatal pain that is dismissed as normal discomfort. What does this best illustrate? A. Reproductive education gap. B. Implicit bias and dismissal of prenatal pain. C. Improved patient-provider communication. Or D. Maternal satisfaction increase. The answer, B. Implicit bias and dismissal of prenatal pain. Over the past decade, data shows a troubling pattern. While cardiovascular survival rates have improved slightly, maternal mortality for African American women has widened compared to white women. Breast cancer mortality remains disproportionately higher, even as overall cancer survival rates improve nationally. These trends reveal a critical truth. Without intentional efforts to address inequity, progress in medicine will bypass the most vulnerable. Knowledge check number 4. Which statement correctly reflects health trends over the past 10 years for African American women? A. Maternal mortality rates have improved significantly. B. Breast cancer mortality is now equal to white women. C. Cardiovascular survival rates improve slightly, but maternal mortality gaps widen. D. All of the above. The answer, C. Cardiovascular survival rates improve slightly, but maternal mortality gaps widened. When we examine the data, 3 medical areas stand out as the most heavily affected for African American women. The first is maternal health. Black women are at the greatest risk of preventable mortality during pregnancy and childbirth. The CDC reports that they are 3 to 4 times more likely to die from pregnancy-related complications than white women. These deaths are often linked to preeclampsia, which is high blood pressure and protein in the urine, hemorrhage, which is loss of blood from a damaged blood vessel, and cardiomyopathy, which is disease of the heart muscle causing it to have a hard time pumping blood to the rest of the body. These conditions are largely preventable with timely, attentive care. As Dr. Amuta Anukanga emphasized earlier, reproductive justice means listening to patients, respecting their voices, and ensuring care that is free of dismissal and delay, regardless of a woman's background or income level. Cardiovascular disease. Heart disease, which is a group of conditions that affect the heart and blood vessels, remains the leading cause of death among African American women. Disparities are especially stark in hypertension, which is high blood pressure resulting from blood thrusting too hard against an artery wall. This develops earlier and progresses more aggressively in this population. Black women are more likely to be hospitalized for heart failure and less likely to receive guideline-based treatments such as ACE inhibitors or cardiac rehab. As Dr. Lisa A. Cooper's work demonstrates, patient-provider trust and culturally competent communication are not just soft skills. They directly influence whether patients receive and adhere to life-saving cardiac interventions. Breast cancer. Although breast cancer, which is abnormal growth of cells in breast tissue, is similar across racial groups, mortality rates are disproportionately higher for African American women, about 40% higher than that of white women. Later stage diagnosis, barriers to timely treatment, and higher rates of triple-negative breast cancer all contribute to this gap. Here, Dr. David R. Williams' research helps us connect the dots. Chronic stress and systemic discrimination influence both access to preventive care and biological stress responses that can worsen health outcomes, including cancer. Together, maternal health, cardiovascular disease, and breast cancer form the front line of inequity. Tackling these issues requires not only better clinical practices, but also the systemic changes our experts have called for: listening to patients, building trust, and dismantling discrimination at every level of healthcare. Knowledge check number 5. Which 3 medical areas are most affected by racial disparities among African American women? Choose all that apply. A. Endocrinology. B. Breast cancer. C. Maternal health. D. Cardiovascular disease. Or E. Respiratory disease. The answer: B. Breast cancer. C. Maternal health. And D. Cardiovascular disease. Understanding these disparities is only the beginning. In the next video, we will look closely at how inaccurate assumptions and implicit bias shape medical decision-making and what you can do to interrupt them. Knowledge check number 6. Which of the following best defines health disparities? A. Genetic differences that cause unavoidable outcomes. B. Random variations in data. C. Minor differences in patient choices. D. Preventable differences in health outcomes linked to social, economic, and environmental disadvantage. The answer: D. Preventable differences in health outcomes linked to social, economic, and environmental disadvantage. Next question. What well-known athlete experienced discrimination and implicit bias that almost cost her her life? A. Venus Williams. B. Simone Biles. C. Angel Reese. D. Serena Williams. The answer: D. Serena Williams. Next question. What communication barriers contribute to racial health disparities? Choose all that apply. A. Dismissing patient concerns. B. Lack of cultural awareness. C. Implicit bias. D. Active listening. The answers: A. Dismissing patient concerns. B. Lack of cultural awareness. And C. Implicit bias. Next question. Who developed the Everyday Discrimination Scale? A. Dr. Amuta Anukaga. B. Dr. David Williams. C. Dr. Lisa Cooper. Or D. Dr. Charles Drew. The answer: B. Dr. David Williams. Next question. Maternal mortality among African American women has improved significantly in the past 10 years. A. True. B. False. The answer: B. False. Final question in your knowledge check. What were the names of the 3 enslaved women subjected to non-consensual experiments by Dr. J. Marion Sims? A. Harriet, Rosa, and Fanny. B. Betsy, Lucy, and Anarcha. C. Ruth, Wanda, and Bernice. Or D. Betsy, Lucille, and Annalise. The answer: B. Betsy, Lucy, and Anarcha. By engaging with this training, you are choosing to be part of the solution. You are choosing to deliver care that is equitable, evidence-based, and just.